All right. Thanks, everyone. Welcome back. I want to welcome Maritza Pedlar, who's going to be our moderator for this. She's our new Well Cities Director at the Economy League. And yeah, she's going to moderate this great discussion on maternal health in the Philadelphia region. So go ahead, take it away, Maritza.
Hello, good morning. My name is Maritza. I'm the Program Director for Impact Labs and running the Well City Challenge for this iteration between 2022 and 2024, which will be focusing on health equity, and we will be accelerating everyday innovators in Philadelphia that have ideas for health solutions. So for this panel, we'll be having our conversation about maternal health, and we hope that this conversation will quote unquote unlock any ideas that you may have not had when you arrived, and that discussion will really bring about new approaches, better ways to manage employees, and lessons learned that can cross sectors and within the general Philadelphia region for change and development in healthcare. So I would like to begin by having our panelists introduce themselves, and we can begin with whoever would like to start and just introduce yourself and what hospital or system you represent and a bit of background about yourself.
Sindhu.
Sure, I can go first. Hello, everybody. My name is Dr. Sindhu Srinivas. I'm a professor of OBGYN and director of obstetrical services at the Hospital of the University of Pennsylvania. Quality and safety in the department and the physician lead for the women's health service line across Penn Medicine. I'm a clinically practicing high-risk pregnancy doctor, healthcare administrator, as you just heard, with several kind of healthcare leadership positions in our across our system, and also have a research program in maternal fetal medicine with my sort of really current research focus evaluating innovative healthcare delivery strategies to improve maternal outcomes and improve equity. David, I can pass it to you.
Thank you. Good morning, everybody. My name is David Jaspan. I'm the chair of obstetrics and gynecology for the Einstein Healthcare Network in Philadelphia and in Montgomery County. I'm also the chief quality officer for Einstein. And my research interests look at patient safety and quality, as well as advanced surgical training. Olan.
Thanks, David. Thanks, Sindhu. So my name is Dr. Olan Soremekun. I am not an OBGYN. I'm actually an emergency physician by training. I am the CEO and co-founder of Care, which is a home-based maternity solution that partners with practices and healthcare providers to provide an extension beyond the walls of the office to meet needs of patients in the communities. Provide a little bit of context. I practiced in emergency medicine in Philadelphia for over 8 years and sort of saw firsthand sort of some of the challenges patients had navigating sort of a complex system. Excited to work in Philadelphia where we have some of the most amazing institutions and partner with folks like David and Sindhu on some of the work. But happy to speak more about that work, but that's my quick intro.
Thank you. So this conversation will begin with just an outline of the current ecosystem of maternal health care in Philadelphia, and then we'll move more into a discussion about network and benefits and the network of the industry and patients, and hopefully just close out with some questions and discussions with attendees. So my first question for our panelists are, I'd really like for you to frame some of the challenges that you face in your work. And some things that we discussed previously included maybe scaling effective solutions, identifying cost margins, and measuring outcomes appropriately. What challenge areas weigh heavily on your mind? And what are the most pressing issues, in your opinion, in Philadelphia?
I'll start, I guess. We're continually hearing about maternal mortality and maternal morbidity. And the fact of the matter is, whenever we hear that, speaking for Sindhu and myself, because we've had this conversation, it immediately feels that the public perception is that the care inside the walls of the hospital, the prenatal care, is the fault. And if we could just fix that, everything would be okay. The fact of the matter is in Philadelphia and in Pennsylvania, we review every maternal death, and almost all of them occur outside the walls of the hospital. And so how we as providers and healthcare organizations can meet needs of patients that spread beyond the walls of the hospital is currently our biggest challenge.
I'll just add to that. I couldn't agree more. I think that historically, we've really focused on maternal health, and as providers, like thinking about the care we're providing at the time that we're seeing the patient and in the confines of, let's say, for me, a pregnancy. But what we know, and I think what is not surprising, right, is that circumstances of people, their like life course, their access to food, like all of these other things really impact their health. And if we really want to improve the health of birthing patients and their infants and their families, we have to really think about how to incorporate all those other pieces into our care. And that hasn't been sort of traditionally, and we're not the best people to do that either, right? We don't have all the skill sets to sort of think, to sort of have all the resources to do that. And so that's where I think right now our biggest challenge is in thinking about how to create better systems and collaborative systems of care delivery that would enable us to really address all of these other things that really impact patients when they're pregnant, and certainly for the time following their pregnancy, when we see a lot of the morbidity and mortality occurring.
And I think one of the things that I might sort of add to that, and when we sort of think about some of the term social determinants of health that drive towards poor outcomes, we sort of recognize social determinants of health being food, transportation, housing, childcare are really important factors that actually impact the ability to actually drive towards improved outcomes. A couple of points around that is, we in general might think about folks that have those gaps being maybe on the low income side. But want to really sort of call out that in the commercially insured employer-sponsored plans, a significant portion of those patients that are covered by those plans, up to half, might actually have a social need that's impacting their healthcare, food, transportation, housing. And that number is significantly high for the Medicaid population, where almost 75% will have that gap, but up to half of commercially insured patients. The second thing that I would call out, and we're all physicians on the panel, patients don't necessarily tell their physicians their challenges. Like when you ask the patient, is everything okay? They might want to bother you with, I'm food insecure, or I don't know how I'm going to navigate X. And so what we do know is that we have to give patients that sort of trust and relationship in the community. And we need to ask multiple times over the course of the pregnancy to identify where we can actually help patients sort of close those gaps. So that is sort of one of the key factors that we're working on in our partnerships.
Thank you. And Sindhu or David, do you have any, I guess, anecdotal experience or things that are happening when it comes to, I guess, eliciting that information from a patient when you're working with them or within your team to identify those gaps that Olan kind of just shed light on?
It's funny, when you just were asking that question, I was about to sort of say that, kind of an example that I could give, and this is just someone that I saw recently in the office, is, I think we have a clinic where we see a session in our office where we see patients with diabetes, either in the pregnancy, gestational diabetes, or people that have pre-existing diabetes but that are now pregnant. And in the clinical setting, right, we're kind of focused on, well, we need their blood sugars to be a certain level, and that's the thing that's going to help optimize their outcomes. And many times a session, there'll be patients that couldn't do all the testing that we had asked or we had recommended. And there was one patient in particular that just kind of week by week, just really wasn't able to provide some of this testing values. And when we really got into sort of what was preventing her from doing that. Because, you can, a lot of strategies that we can work through to try to help facilitate this. But it came up that she was really stressed about her food situation, right? And so, and when you think about sort of all the things on her mind, of things that she needs to do in her day with her other children, and we're in the office focused on, well, we're focused on like the fact that we need these values of this test, and she's worried about whether she can actually provide food for her family. It sort of reframes, kind of creating a more collaborative approach with the patient to say, okay, like let's just think about like what aspects are actually important. How can we help figure out how to get you what you need, but also what we're asking of you to make that a more of a realistic ask, rather than something that's not attainable. And then you just feel bad that you're not doing what your medical providers are recommending, which nobody wants to do that. And so I think those types of interactions happen every day. And from a medical perspective, we've always been, understandably so, because that's what related to outcomes, the tests and the values and what we want the patients to do. But that's always in a broader context of other circumstances. And we just have to take that into account, or we're not going to make a positive impact on patients and their health.
Let me just share this. So we recognize that the population we serve has significant food insecurity. So we partnered with Philabundance to create free food, 5 pounds of food every week for patients right on campus. It was a failure. It was a failure. We brought the food to the patient. We were doing what we thought was right. They may not have a stove or a refrigerator to do anything with that food. So our ivory tower approach failed because we weren't in the community recognizing what their actual needs were. And though these examples are endless, sadly, they're endless. But let me also share with you that 2 people who are recognized by first name only shared the same thing. So Serena and Beyonce, in their pregnancies, both had almost near-death experiences because someone just didn't listen to them. And so it's about not just people who we see who have less resources. Nobody has more resources than Serena and Beyonce, but people didn't listen to them either. And so this is pervasive, and we need to change our training to be able to better meet needs of communication and understanding what people really need down to the level of their personal needs.
And I think, David, just to piggyback on what you just said in terms of coming up with a solution that maybe is well-intentioned but doesn't actually succeed, is often, I think now we're much sort of more active and proactive about really having patients and the patient voice and the lived expert voice in the development of our solutions. We're not trying to, oh, it's food, so let's just bring food and that's going to fix it all. It feels like it should, but we know even from quality work that when you're solving for the wrong problem, you come up with the wrong solution. So, but involving the people who we're trying to help in the solution. I think lots of examples of programs across the city, and even, the new action arm of the Philadelphia Maternal Mortality Review Committee, the OVA, Organizing Voices for Action, has, lived experience experts on the committee to really bring that voice. And I think that that's an incredibly important, and I think more fundamental part of the work that all of us are doing, is that we're not doing it ourselves. We're doing it with our patients and with our patients' sort of voice.
Yes, and I love this conversation around, partnership, trust building, and just also how do we know what the proper intervention or like technique to, address these issues are. And that's one thing with the Well City Challenge that we really hope to cultivate, working with the community and understanding what their exact barriers are, and maybe not just what we would assume. The barrier could be to maybe, having healthy food so they can obtain heart health or mental health services. So then so empowering people within the community that either provide informal resources and services or have an idea to provide a service can be connected with, people within health systems and leaders like yourself. So then we could work collaboratively to provide more targeted services and also continue to cultivate leaders within the region. So I love hearing this. Olan, did you have any comment to add? I saw you unmuted yourself.
Yeah, no, I think that there are lots of different facets to the problem. David's talked about Serena and Beyonce having poor outcomes, and we know that it's multifactorial. We talked about social determinants of health. We talked about building, for us, trust in relationships, so that one, the patient feels comfortable sharing with their provider or the health system and the care team, and vice versa, like the care team hearing what the patient is saying, right? And I think, we started off asking, like, how do you scale, right? How do you scale this, and how do you build those solutions? I think everyone on this call, my co-panelists all will say, we need to be in the community. We need to extend beyond the walls. We need to build trust and relationships. And the only way for us to really do it is through sort of innovative partnerships. And to do it at scale, it's to partner across the entire sort of stakeholder community when it relates to impacting outcomes. So complex problem, but really will take innovation for us to do it and make meaningful impact.
Maritza, I think you're muted.
You're on mute.
Sorry, thank you. So I wanted to move on a bit and talk more about maternal health outcomes. Mortality and morbidity metrics are not linked directly to quality of care, which we've touched on already. But how are you working to address these challenges that affect your patients? And what kind of control do you feel you have or not have, or perhaps would like to have when it comes to issues that pertain to influencing maternal health outcomes?
I can start that one. I think it's first important to say maybe what you said in terms of the kind of outcomes and quality of care. It's partly about what are the metrics that we are choosing or selecting, right? And I think there's a way for us to think about defining quality differently, having it be about certain processes of care, about transitions, about connection to some of these resources. And when those are the things that are prioritized and that incentives align with those priorities, then I think we will be able to kind of align those things together. I think kind of some of the traditional quality metrics in maternal care are all sort of, as we've said before, more hospital-based care metrics, and not necessarily the harder things that are the things that happen outside of the hospital once patients go home. And I think one of the biggest challenges in that space for me, and what keeps me up at night when I'm on service and I discharge patients, is the transitions of care out of the hospital. Just knowing that that's a very high risk time, making sure that we've identified any resources or needs that people might have before they leave, and then how do we make sure those connections happen, and what's the closed loop back to me as a provider to know those things happened. And that system is not functional. That's a very difficult the transition out of the hospital is one of the more difficult, I think, aspects of care delivery. And I think that's definitely something as a provider, when I see patients that I spend a lot of time talking to patients about their transitions of care and handing off, and potentially even, calling other providers to hand off specifically if I'm really concerned about something. But that's a lot of the system doesn't facilitate that in a way that makes it easy. And I think that's a significant challenge.
Sindhu's being a little bit modest. So Sindhu is part of a team that created something called Heart Safe Motherhood, which we are fortunate enough to share across the city through a grant from Merck for Mothers, led by Asta Mehta, who was mentioned in the chat, is a colleague and works with Sindhu and I on a very regular basis. But Heart Safe Motherhood does enable patients with hypertension to monitor their blood pressures at home, and by text and artificial intelligence, provide that information back to the physicians. And if the numbers are not where we'd like them to be, there's opportunity for immediate contact. So through new technology, we are able to close a loop, at least in one sense. It's not perfect, but what I want to use the opportunity here to let people know is that in the city of Philadelphia, there's only 5 hospitals that deliver babies. There's really 3 healthcare networks: Jefferson, Penn, and Temple. That's it. And we all meet on a very regular basis to use things such as Heart Safe Motherhood, which was shared from Penn to everybody else, simply to impact the care that we can provide and the outcomes that people deserve. And so it's competition free. It's about providing the highest level of care for the most number of patients that we can.
And I think in terms of sort of the community health approach, so our solution at Kayaba Care is really centered around hiring women from the communities that we serve, similar to a community health worker approach, and we call them maternity navigators, that we sort of equip with additional training, technology, and a team to support them going into the home. I always joke, I was like, what we're doing, we raise capital to sort of build out in Philadelphia and hire and build the workforce, but it's not really innovative, right? The community health approach has been studied and published on in many different populations around the world in developed and underdeveloped countries. But really, I think what we are doing that is innovative is on 2 folds. One is that we believe really strongly that we have to integrate with providers like David and Sindhu at Penn, right? And we need to do it in a way that there is closed loop and we're sharing data back and forth, because they know the plan of care. They know what patient is at risk. They know what the patient clinically needs. We can put it in the context of what is their lives at home and what are the barriers to achieving that plan of care and how do we get there, right? So I think that's it. That's one of the innovative approaches that we've taken. I think the second thing is that we've seen a lot of really innovative and great grant-funded solutions, which is great. But what happens when the grant actually ends, right? And so for us, the way that we actually have to be successful is to plug into the payment system in healthcare. So we need to partner with insurance companies to basically demonstrate the value of this approach for both mom, birth an individual baby, and actually demonstrate that there's a positive ROI to invest in this, right? And so those are the 2 things that we're doing that are somewhat different, and we're excited to sort of do it in Philadelphia and sort of build that workforce. But it's that integration with the in-office practice. And it's that plugging into sort of the regular payment model that we believe is innovative.
Definitely, a lot of those extra services are not covered by insurance. So, it'd be so beneficial if mothers can have that extra support from community health workers. When David mentioned the collaborative between all the health systems, and I would especially be interested, Olan, like in your perspective as well, working with community health workers, how collaborative and how accessible are those networks to community health workers, and like, are those doors open on both ends when it comes to collaborating across all the health systems, the primary players?
Yeah, so I think one of the amazing things about Philadelphia, especially on the maternity space, is the level of collaboration that exists across all the health systems, where there's truly not a competitive, it might happen in other specialties, but there's truly not a competitive angle to it. I think everyone is sort of aligned with what we ultimately want to achieve, right? So it's healthier communities, better birth outcomes, healthier babies, right? And so what we found is like the health systems are really eager to partner together and to work together towards that sort of shared goal and objective. And so it's been a great sort of community to sort of work in. I can't really say that for some other cities, but I think in Philadelphia, the environment is definitely very collaborative and welcoming to innovation in the space.
Nice. And Sindhu and David, I'd be interested to know, are there any programs within your hospitals that help subsidize, I guess, fees for community health workers or other types of providers, whether it be like a doula, that patients will be bringing in, especially when we mention things like Beyonce and Serena and the challenges that especially women of color, mothers of color may be feeling. Are there programs that, you know, the hospital is working on to help make these services more affordable for patients?
You want to start, Sindhu?
Sure. I think I'm going to zoom out for a second and just say that I think all of these services are important for patients, but it's also important to individualize our approach. Like different patients need different things. And so a community health worker or a doula service isn't necessarily going to be the sort of the fix-all for every patient, I think, but the fact that we all believe, I think that it should be available and it's a service that should be kind of offered and available. We partner at Penn with a like Philadelphia-based doula service. And so it's offered to every patient when they arrive, if they're interested, if they would like a support. Some people hire their own private doulas that they might have partnered with prior and during the pregnancy. I think during the pandemic, the accessibility of doula support has kind of gone up and down a little bit for a variety of reasons. We know that there's a lot of shortages around a lot of workforce areas. I think that's another one. We developed a community health worker type of program with the Maternity Care Coalition, which is a really well-known nonprofit organization in Philadelphia that's been around for decades, providing a lot of direct services to patients in a variety of different spaces. And like 5 or 6 years ago, we got a grant to sort of develop a community health worker or type of program with them. And that program is something that is still available to our patients at Penn. And then Penn has an entire community health worker center that is not just for them, that's not in the maternity space necessarily only, but just broadly for patients across multiple different sectors after being discharged from the hospital. So I think there's a lot of work in that space, but I think what we know is that we should be kind of trying to really individualize support. And I think what's, Olan's model of Kayaba care, what we think is so kind of unique about it is it sort of like allows you to bring together every piece and kind of figure out what patients need and then partner them with those pieces. And so we, are hoping to, embark on a research study of that kind of model of care delivery to really be able to provide some high level evidence. Because I think high level evidence and partnership with payers where payment systems are aligned with the care you're trying to provide those are two, I think, key pieces to really scaling solutions that work.
We have multiple grants for doula services, but the doula services there's a hybrid, right? There could be the doula who meets the patient for the first time as they present to labor and delivery, or the more traditional doula service where they meet the person as they go through prenatal care, learn about the family, etc. And what I'll share is that we have a grant for both, but in recent times, over the last 18 months, our patients didn't want the doula to come to their house. And the grant somewhat requires the doula to go to the person's house. And so we'll be at risk for not achieving the grant outcome because our patients are declining that. And so it's, again, to what Sindhu said, it's the individualization of the care model so that we can meet patients' needs, not meet groups of patients' needs. We also have community health workers for substance use disorder. We have it for behavioral health disorders. If the question was asked to me right now, what is the greatest threat to our patients, their overall health, I would tell you it's in some degree of order, probably cardiac disease, behavioral health, and substance use. And we it's very difficult because there's no resources. There's no one working in those fields right now. It's really very difficult. We have the positions open, they're funded, can't hire anybody. Which to be very honest with you, the insurance companies, the Medicaids, the major Medicaids in Philadelphia, we recognize Health Partners and Keystone First, they have resources for all of the things that we need. And very honestly, the reason that we decided to partner with Kayaba is because they were going to help us to navigate and enable the patient to get the services that that individual patient needed from their healthcare insurance company. I could do that if I had probably 3 extra hours for every single patient, which obviously we don't have.
Thank you. I love the collaboration across networks. So I'm going to move the discussion towards the concept of pay for performance and how that affects your approach to innovation and providing patient care. We talked about this a bit during our call, and how the role of being a disruptor and evolving the model of healthcare from good to great can be difficult based on the current model of pay for performance. So what does this look like for each of you and your role in the health system?
Olan, do you want to start?
Yeah, no, would love to start. I think when we think about pay for performance, I think everyone on this call will sort of agree more and more we should align payment to the outcomes and the impact that we have. So I think we all agree on that concept. I think it's really important for us when we sort of think about pay for performance is that we're paying for the right metrics at the right outcomes, right? So, when we sort of think about not everything that you measure matters and not everything that gets measured net right now, I forget the saying, I'm stumbling all over it, but we're paying for a lot of things that don't really matter, right? Like, how do we identify the right things that matter and make sure that we align? I think in terms of pay for performance as well, I think it's really important to sort of call out like maternity specific pay for performance measures. So there are times where we bundle it into overall pay for performance for the entire sort of total healthcare spend. But the fact is, I think maternity is really unique, especially for mom and birthing individuals and newborn babies. And to truly call out, what are the metrics that we want to sort of incentivize across both birthing individuals and babies, and how do we pay for performance around those key metrics? I think those are one of the things that where we know that if we do not align the payment model to what we believe adds value and metrics that actually add value, we'll have great innovation like Hot Safe Motherhood that doesn't get implemented because we haven't aligned it. And so that is, something that I do feel strongly that we need to sort of align if we're going to sort of make advances in terms of maternity care in Philadelphia. But I'll pass it over to Sindhu and David to add on.
Good, Sindhu.
Go ahead, David.
So we're still paid. Pay for performance doesn't truly exist in obstetrics. We're still paid fee for service. We see the patient, we charge, and we get reimbursed. That's not optimal. Patients struggle to get to us. Patients struggle for a whole host of reasons. And so therefore, we need to completely disrupt prenatal care and recognize that most of the technology exists. And in fact, I suspect that all the technology exists for our patients to be able to perform their prenatal visit from home. However, in the height of the pandemic, there was an article in the New York Times, so not from Philadelphia, but a significant portion of patients in New York did not have access to internet in their home. And so if we were to do that, we would have to ensure that the mechanism to make that happen were real for our patients. But we also have to recognize that if the patient didn't present to my office, I have to align with the insurance company to ensure that I'm not going to detract from ourselves getting reimbursed. And I can tell you, we saw that truly happen. When we were diminishing the number of ultrasounds that we were doing so that we could enable patients not to have to trek to the hospital, our revenue went down. Our outcomes got better, but our revenue went down. And that disconnect is not sustainable.
Yeah, I think I don't have a lot to add, except that I'll just hit home the point again of the alignment of sort of payment with the services and the outcomes that you're trying to achieve. I think we're in a place where we're looking to disrupt and we're looking to innovate because we know that traditional prenatal care that's been around for centuries in the same way with the same number of visits for every patient doesn't work and is not optimal for everybody. And so, but in order for that disruption to be successful, when we develop new ways to do things and we develop new programs, those have to be aligned with the payment system. And I think that those two things are definitely disconnected. And Olan brought up the example of Heart Safe Motherhood. We've had multiple articles published. We did a randomized trial. It's evidence-based, and we still are having difficulty kind of with how to get that reimbursed in a sort of sustainable way. And that is a barrier to other health systems and hospitals, being able to scale that sort of more broadly, even though we've demonstrated elimination of disparities in the care of patients with pregnancy-related hypertension. The other thing I'll just say, which is I think stepping out of the box a little bit, is that pregnancy and the postpartum period is sort of always thought of in this like sort of episodic kind of way. Like this is like a finite time and we're just trying to impact this time. But when you think about what leads to a healthy pregnancy outcome, it's all the things that happen before the pregnancy. When you think about what happens, the morbidity and mortality after the pregnancy, it's all the things that are happening after the pregnancy. And you think about pay for performance or things in the primary care space or in the preventive space, pregnancy is like this sort of carved out episode that's not really aligned with the way that primary and preventive care is sort of thought about. And I think there's a real opportunity to incorporate some pregnancy related care, health, pre-pregnancy, post-pregnancy into that more preventive health space in order to really truly optimize pregnancy outcomes. Because it's not just about what we can do while someone's pregnant that leads to the most optimal outcomes.
If I could just expand on that real quick. So there's something called HEDIS measures, which insurance companies are held to, providers are held to. And one of them is cervical cytology, getting a pap smear. And so people rely, I think, traditionally on the OBGYN to do that. But some patients don't go to the OBGYN. They might present to their primary care physician because they had a cold, ear infection, or something else. But sadly, many family medicine, internal medicine people don't do a pap smear. They're not equipped to do it. They don't have the right tables, the right instruments, etc. But the fact of the matter is, that's the touch point for that particular patient. And we have to not only collaborate with people like Kayaba and third parties, but we have to be able to collaborate within our own network to ensure that the patient gets the care that they need and deserve. And this can be for colorectal screening, mammography. So the list is endless, and we can do a better job, and there's technology that can enable it to be easier.
Thank you. And the last question I have before we really open up for the open discussion and questions from those in the audience, in one sentence, can you offer advice to employers who want to provide their employees with more equitable healthcare offerings? And maybe we could start with Sindhu.
From a sort of pregnancy, maternal health kind of space, I think health insurance for birthing people should incorporate infertility treatment, contraceptive care, and pregnancy abortion care or discontinuation care. I think those are things that are part of important aspects of reproductive health and also really of maternal and family health. And I think kind of any sponsored insurance for employees should really incorporate that.
We're all aligned on this. There's no way that full scope reproductive health insurance must cover everything. Otherwise, it's a detriment to people who are female.
And so the one additional thing that I would say to piggyback on that is really for employers as the purchasers of insurance to really think through sort of their health benefits as it relates to maternity and how they support patients, spouses, families, dependents through the episode more broadly in terms of what additional benefits could cover. Not only is it a health benefit, but it's actually a way to recruit and retain talent. And you're the purchaser as the employer when it comes to sort of that health insurance for your employees if you provide that coverage. So really spending time. I think the second thing, I think you said one sentence, so this is a run, this is like the worst sentence ever, is to truly talk to your employees that are going through it, right? I think it's really powerful when you sort of understand and you talk to someone that has recently gone through it to identify what are the places of where change is needed, how can we support employees better. So I always feel that's a really powerful story when you actually talk and hear firsthand, what your health insurance dollars are actually purchasing.
Thank you. Well, first of all, thank you all for answering these questions and providing your insight. I'm now going to open up the floor for questions. You can feel free to raise your hands through the chat or just unmute yourself and jump in to ask a question, or you can, throw a question into the chat, and if I see it, I'll read it out loud.
Can I just, while people are putting things in the chat, I'll just say that I think this is a really great conversation and a great opportunity for kind of cross-pollination across different sectors around maternal health. And I think success will be the most likely if there is that continued kind of multi-stakeholder engagement and involvement. So it's not, it's like the medical care providers with companies like Kayaba, with businesses and employee-sponsored health insurance, with health insurers. Like this is a societal crisis, maternal health in this country, and it will take all of us together to come up with those solutions together. And any individual group doing something in their own lane without kind of involving the broader stakeholder group, I think won't be successful. So I really appreciate the opportunity for us to even have this conversation with, I think for me, at least not necessarily always others that I regularly interact with that are listening to this panel and participating. So thanks for the opportunity.
Yes, one question that I did notice that came through during the conversation is how did the COVID-19 pandemic impact maternal care and maternal mortality in Philadelphia?
And David, you might want to add in, but I mean, I think the biggest impact it had to care was, as David sort of alluded to, kind of a reduction in ultrasound. I think it made us really think about the risk benefit of in-person care and what could be done sort of either, spaced out or done from home by telehealth. I think it exponentially ramped up telemedicine visits and showed us that we could actually do that and do it successfully, even though there's a lot of discussion about it before. It kind of accelerated that. And so for us, we similarly really kind of reduced some visits, both prenatal and some ultrasound visits. From an outcomes perspective, I don't think we've really seen, at least in a more national evaluation that I've done from a research perspective, there was some anecdotal kind of comments about whether there was an increase in fetal demises during the pandemic and in other kind of adverse outcomes. And in some of the research that I've done with a broader national database, we haven't seen that to be the case. And I don't think we necessarily saw that play out in Philadelphia either, but I'm curious to hear David's comments as well.
I agree. I think there was anticipation that something could happen, but I don't think we saw the realities of that, thank God.
Another question that came through from Susan Crosby is, what are actionable items that individuals can do to improve maternal health outcomes?
I mean, I actually think it's being your own best advocate and recognizing that or the patient knows their body. And if you're not getting the answer or feeling heard, then make sure that you are.
I think I always will say, I guess it depends on what the individual is. And I think the one thing that I would say is, I think it is a significant life event, and it's really important for anyone going through it to have the right support, and support being clinical, support being navigation, support being someone that can think through and just help you through the emotional stress of going through that episode. So I think one of the things is that no one should go through it alone. And it should be highly sort of personalized. I think as employers, figuring out how to support patients through it, and not just health benefits, but there are lots of concerns around lost wages, maternity benefits, paternity benefits, and post-loss, like time to time off, and lots of things that we could sort of really think about, like how do we create the social safety net as well as the support during the episode so that we get better outcomes. Lots of different things, but I would say it's worth sort of just calling out and giving voice to the issue so that the key stakeholders will continue to sort of engage in terms of how we make it better.
Thank you.
Maritza, there are a couple of hands that are up just to let you know.
Yes, definitely moving on to the hands. Jeff, you have a question? You can ask the panelists. Please.
Yeah, I have several. This has been wonderful. Thank you so much. I'm Jeff. I run the Economy League, and Maritza and Kirsten have done an amazing job organizing this panel. Maritza mentioned our Well City Challenge. It is designed to surface community-driven solutions to health equity challenges. And so one of the things that I'm a historian by training. I worked in the labor movement for 10 years with service sector unions, particularly SEIU 32BJ, which represents janitors. And there's a very deep distrust in community of traditional healthcare institutions, and not because any of you guys are doing anything wrong, but it's just, structural racism and distrust is kind of baked into the system. So there are some deep equity concerns here. I'm wondering if you've ever considered working with some of the public employee unions or the service sector unions to try and build trust between institutions that working class people trust, like their unions and churches, to help bring people more into the system. That's question number one. And number two, what can we as a business-centric organization do to help you deal with the mismatch between payment systems and outcomes? I mean, it's just like the most maddening thing. We know it works, but insurance won't pay for it. That seems to be so perverse. So any thoughts on those two questions?
I'd like to address the first question, if I may. I think that it's important that the data is crystal clear. It is important that the healthcare provider looks like the patient looks like the healthcare provider. We are in a position where we are, Sindhu and myself, that we can recruit people. But the fact of the matter is we need people like yourselves to enable people to understand and recognize that this is an achievable goal. Working in healthcare is an achievable goal for them. I think it goes back to elementary school, high school, to give people access to opportunities, to shadow, to see what it's like, and to recognize that their future could be in medicine. I was fortunate enough to work with an organization in Philadelphia called Icon Sports, which serves North Philadelphia underserved people. And we partner with them to give these young women opportunities to shadow in the hospital. And they then use their sports ability to get Division I scholarships to go to school where they may not have been able to go. And so it starts the path there. I really do think that we need to be a part of that, but we need everybody around to help people to recognize that this job, nursing, CT tech, ultrasound tech, pharmacy, physician, whatever it is attainable to them. Because you're right, there is a mistrust, and it goes very, very deep. And it makes it really hard, speaking as a privileged white man, to care for someone who doesn't look like me. I still think I do a good job, but it makes it really difficult. And I have to go into that interaction with eyes wide open.
I could, oh, go ahead, Olan.
No, I think the one thing that I'll add, I would love Jeff to, when we talk about like the unions, right? You're correct. Unions, churches, local community-based organizations are really important, and would love to have a conversation as to how we could work with unions to build that trust, right? Because it's a two-way dialogue, and I have ideas and thoughts, but would want to foster that conversation. I think the second thing that I would say is, for a lot of unions that actually pay for their own health benefits, right, and cover health expenses, would love to sit down and talk about, how do we specifically call out maternity, right? We know it's a high use area. We know that ultimately, even though the insurance companies might be administering the health benefits, it's paid for out of the union dollar. So would love to talk about what benefits.
Yeah, we definitely, SCIU 32BJ has 250,000 covered lives in its health plan. Immense leverage there.
Yeah. And so I think you could drive the conversation a lot. If you,
it seems to me like there's a missing link there. I just don't know that the healthcare because healthcare systems tend to see unions as adversaries because they're always trying to organize the nurses, which I get, but there's a huge client population, and there's 150,000 union members in Philadelphia. So there's an opportunity there that I think is ripe for exploring anyway.
Yeah, would love to chat about it, and maybe I'll pass it to Sindhu.
I was going to say the same thing. I think there's two or multiple aspects. David touched on pipeline programs and really thinking about how to increase diversity in the general healthcare workforce, which I think we have a lot of different programs trying to partner with high school students, health education. There's lots and lots of programs. We do that at some of our professional meetings too. And I think that's a really important aspect of the work that's longitudinal. And then there's the part, honestly, Jeff, I hadn't really kind of thought about that sector before as sort of a very kind of embedded in the community and a really important kind of stakeholder group to really think about having conversations. I will agree with, I would love to have a conversation with that about how, just thinking about a bi-directional conversation about trust and about what are the aspects that
bi-directional, totally.
And about trust and sort of what are their experiences with healthcare, and then also, and obviously there's leverage from the kind of insurance kind of perspective piece as well, but just about sort of the trust sort of piece in particular. And I think your second question was about payment and aligning payment. I think I want to believe that it's slow to move and it's eventually going to happen. I think we brought up the example of Heart Safe Motherhood. It's something that we've been kind of working on as a group of city leaders for a while, and our payer partners are super kind of engaged with us on trying to think about this. I think at the end of the day, innovation and just innovative programs in general that utilize technology has not been the way healthcare has been delivered. So when you ground everything in a actual in-person visit as the base for the interaction, it's already not going to work because that's just not the interaction you're talking about anymore. And so I think there is going to have to be some disruption in that space around what is considered a healthcare interaction. It's not anymore that somebody's coming to your office. That's one of many kinds of interactions. And I think we just haven't gotten there yet. But I think with all of the different beating of the drum, if so to speak, I think it is sort of moving in a direction where that's being acknowledged.
Yeah, it's crazy. Are you familiar with the 1199C Training and Upgrading Fund?
Mm-mm.
It's a core pathway into sort of lower level healthcare jobs for union members. Anyway, we should have this conversation offline, but there are mechanisms that exist already that are just not plugged in as they need to be to the larger healthcare system.
And Melina had a question. She had her hand raised before.
Hi, yeah, thanks. This is a vague question a bit, which is why I got cold feet and put my hand down. But it's a little bit of a two-parter. Throughout this conversation, I've been thinking a lot about creative solutions to complex problems. And, you know, in the business world, and certainly now in kind of every industry, because of the obsession with data and measurement, we're constantly talking about scaling solutions. But you've also astutely pointed out many times that we need to have personalized solutions and localized solutions. And the second part of this kind of conundrum or balance needed is between outsourcing or you know, using partnerships like your partnership with the doula organization to develop these solutions for your patients versus developing something that's more in-house, so that there is more of kind of connectivity and communication between all the different pieces. So I guess I was just wondering what your thoughts were on that, especially around the scaling, like how, you know, when all of the funding that we see available these days is by financial institutions and banks that want to see scaled solutions, but all of the social scientists seem to understand that we have to have small, disparate, numerous efforts. How do we balance those ideas?
Maybe I'll take a quick stab. And I know there's a kind of a hard stop in a couple of minutes. I think the couple of things, what I would say is in healthcare, like integration is like really key. So it's not about the solution, is like, does your solution talk to all the other key stakeholders and provide that seamless experience? Like, and we've seen technology firms do it well, where you say something in your house and Alexa knows to show you like what you're searching for, right? And that is the seamless integration folks expect. I think the second thing that I would sort of highlight is the generation of childbirth in like individuals are very different than 20 years ago. People would rather text than talk to you on their phone or see you in person. Like a 20-year-old actually making an appointment for in-person visit is actually just out of context of the norm. Like that is not the reality now, right? It's convenience at your service. I will text. Right. And so it gets back to, we need to sort of really think about the generation that are going to be having children are going to look different and they're going to want to interact with us differently. And if we anchor to the traditional model of, I need to come see you, David, in your office, that generation is not going to like put up with that that much.
I think it's also like, there are certain solutions that help broad populations of people. So we talked about heart safe motherhood, and that's a solution that I think is a good solution for like almost everybody when you come to pregnancy related hypertension. Whereas I think some of the other like screenings around social determinants of health or other things where you need to then sort of like individualize what your approach is, but you need to have the availability of all of those things to be able to meet people with what they need. So I almost think they're not almost like, in my mind, they're not kind of separate, but they're kind of depending on what you're talking about. When we think about in a broad approach to prenatal care, we need to have the comprehensive services. We just need to individualize which services people need. When we're talking about solving for like a specific condition like pregnancy related hypertension, that solution was built with the input of multiple patients from a variety of different, backgrounds. And so the solution is sort of an average or a sort of a solution that is really developed from the patients with partnering with us. And so I think that's why it works and has such good outcome, has some good success for like a variety of different kinds of patients, no matter what their demographic background is. And so I don't almost think of them as separate. It depends on what part of care we're talking about, I think.
That makes a lot of sense. Thank you.
Thank you, everyone. Thank you to our panelists. Thank you to everyone who asked a question. This has been a very great discussion, very rich, fruitful, and I will pass it over to Kirsten as we close this panel out.
Thank you. And I'll release the panelists. I know you have a hard stop, so thank you so much for joining us. We'll share your emails with everyone. Thank you. Appreciate everyone coming today. I know that was a long Duplex 360 event, but we're trying new things this year. We're testing out a lot of different formats. So I really appreciate your time and energy for this and your interest. We'll be sending out a post-event survey to you all. We have these sessions recorded that we'll be sharing as well. So please keep coming to these. We've also just closed our Duplex 360. I'm sorry, we've just closed our Gplex application, but if you really liked this and you want to try and join us for that, send me a personal email. You should all have it. I'll drop it in the chat as well. Thank you all very, very much.
We're going to Detroit. Lots of health equity issues there.
That's right. Stop there.